Welcome to the Australian Dental Council 2026 Explainer podcast.
It's really great to be here.
Yeah. Today we're doing something just a little bit different. Normally we take a pretty broad look at a topic, maybe something trending in the dental news, but today we are getting laser focused.
Very focused.
Right. We're doing a deep dive specifically designed for the high-stakes world of the ADC exams. We're talking about a topic that really sits right at the intersection of public health, pathology, and high-level aesthetic management.
Exactly. We are navigating the rather complex waters of dental fluorosis. And for you candidates listening out there, this is one of those topics that looks simple on the surface. People think, oh, it's just white spots, but it is actually a total minefield in the clinical exams.
It really is. And for everyone listening, especially our overseas trained dentists and the students preparing for the OSCEs, our mission today is to get you OSCE ready.
That's the goal.
Yeah, we aren't just going to recite the textbook definition. We want to actually unpack the specific language the examiners are listening for, the nuances of the diagnostic indices used here in Australia, and this whole concept of the intervention ladder, which is absolutely critical for passing.
And we also need to talk about how you explain this to a patient without completely drowning them in jargon. That's a very common failure point in the communication stations. It's really about demonstrating that you understand the why behind the condition and the how of the modern minimally invasive treatment ladder.
Absolutely. Now, real quick, before we jump in, I do need to drop a disclaimer. In this deep dive, we might mention specific product types or brand names.
Like Icon or Opalister.
Right, exactly. Because they are just the standard in the clinical literature we're reviewing. But this is purely educational. We are not endorsing any commercial products. We're simply trying to reflect the clinical reality you will actually see in the Australian context.
A very important distinction to make.
Okay, so let's unpack this. Dental fluorosis.
Yeah.
To the average person on the street, it's just white spots or maybe some brown stains. But clinically, it's so much more. If you're sitting in the exam and you need to define this precisely, what is the gold standard definition?
You really have to be specific about the timing and the mechanism here. It is a developmental disturbance of the dental enamel, and it's caused specifically by the ingestion of high concentrations of fluoride during amelogenesis.
Amelogenesis being the period of tooth formation.
Oh, that on.
And ingestion being the absolute key word there.
Exactly. You do not get this from, say, toothpaste touching the teeth after they've erupted. It is a systemic issue. It travels through the blood. And the mechanism is actually quite fascinating because people often think fluoride sort of eats the enamel, but it's actually the complete opposite. It's a metabolic disruption.
Right. It messes with the protein removal.
That is the core of it.
Wow.
So during the maturation phase of the enamel, the ameloblasts, the cells making the tooth, they're supposed to remove the matrix proteins, specifically the amelogenins. Think of these proteins as the scaffolding used to build the tooth. Once the minerals arrive, the scaffolding is supposed to come down.
But the fluoride keeps the scaffolding up.
Essentially, yes. The excess fluoride interferes with the proteinases that are supposed to break down that scaffolding, so the proteins get trapped. And because they're trapped, the enamel crystals just cannot grow fully. You end up with hypomineralization and, crucially, increased porosity in the subsurface enamel.
The subsurface. That detail seems really critical.
It is the most critical part to understand. The outer surface of a fluorotic tooth is often hypermineralized and totally intact. It's hard. But immediately underneath that surface layer, the enamel is porous.
Wow.
Yeah, and that porosity is what scatters the light and creates that opaque white appearance.
So it's essentially an optical issue caused by subsurface holes. Now, timing is everything in developmental defects. If I have a, say, 30-year-old patient who moves to a high fluoride area, are they at risk?
No, not at all. The window of risk is strictly during tooth development. The literature states the general risk period is roughly from birth to age 8.
Okay.
However, for the aesthetic anterior teeth, the ones patients actually care about the most, the critical window is usually cited as between 20 to 30 months of age.
Right. Okay, so that covers the why. Now let's pivot to the what. You are in the ADC clinical exam. You have a patient in the chair or an image on a screen, and you need to assess this. I know we all learned Dean's Index in dental school. Is that what we are using here?
Well, Dean's Index is the traditional method, yes. It uses those categories like questionable, very mild, mild, moderate, and severe, and that's based on the 2 most affected teeth. But if you really want to impress an examiner with your knowledge of the Australian context and modern research, you need to be highly familiar with the Thilstrop-Fagerskov index?
The TF index.
Yes, the TF index. It's much easier to say.
Definitely. So why do we prefer the TF index?
Because it's significantly more biologically accurate. Dean's index is a bit subjective. It's mostly just looking at the surface area covered. But the TF index correlates the clinical appearance directly with the histological changes.
Meaning the depth of that subsurface porosity we just talked about.
Exactly.
How does it actually work practically in an exam station?
It's a 10-point scale, going from 0 to 9. And the key diagnostic step, and listen up because this is a massive tip for the exam, you must dry the tooth.
You have to dry it.
Yes, you must dry it. The earliest signs of fluorosis, which would be a TF score of 1, are often completely invisible when the tooth is wet with saliva. You dry it to see the opacities. The TF index is essentially split into 2 halves. Scores 1 through 4 describe opacities without any loss of enamel. The surface is totally intact.
It scores 5 and up.
That's when the subsurface porosity is so severe that the outer enamel literally collapses. You get pitting and actual loss of the outermost enamel. That distinction, intact surface versus pitting, it completely changes your treatment plan, which we will get to in a minute.
Right. But before we treat anything, we have to make sure it's actually fluorosis. This is the classic differential diagnosis question in an OSCE. You see a white spot. Is it fluorosis? Is it molar incisor hypomineralization, MIH? Or is it just early decay? How do we confidently tell them apart?
This is a crucial skill. The absolute hallmark of fluorosis is symmetry. Because it's caused by systemic ingestion of fluoride flowing through the blood, it affects homologous teeth on both sides of the arch simultaneously. It's typically bilateral and symmetrical. Also, the white lines tend to follow the parachymata.
Those are the horizontal growth lines across the tooth.
Yes, so they run horizontally.
Okay, so if I see a white blotch on the upper right central incisor, but the upper left central incisor is perfectly clear,
Then it is highly unlikely to be fluorosis. That points you toward localized trauma, or much more likely, MIH. MIH is typically asymmetrical, and it has demarcated opacities, meaning there's a very sharp, distinct border between the white spot and the healthy enamel. Fluorosis is much more diffuse. It sort of fades into the healthy tooth.
makes sense. And what about caries?
Caries is usually found in plaque stagnation areas, so along the gum line or deep in the pits and fissures. Fluorosis can happen right on the tips of the cusps or on the broad, smooth surfaces where plaque doesn't typically sit.
Okay, that gives us a very clear framework. Bilateral and horizontal equals fluorosis. Asymmetrical and demarcated equals MIH or something else. Plaque areas equal caries.
Exactly.
Let's move to the part everyone wants to know about. Management. We have a patient. They absolutely hate the white spots or the brown stains. What do we actually do?
The philosophy you must articulate in the exam is the ladder of intervention. We always start with the least invasive option, and we move up only if absolutely necessary. We are really moving away from the old drill and fill mentality for these types of defects.
So what is rung number 1 on the ladder?
Vital bleaching.
Just standard whitening.
Yes, standard whitening. It's very often the first step. You'd use 10% carbamide peroxide or 35% hydrogen peroxide. Now, the goal isn't necessarily to bleach the white spot itself. It's already white. The goal is to whiten the surrounding normal enamel.
Oh, I see.
By raising the value, the brightness of the background enamel, you drastically reduce the contrast between the fluorotic spot and the rest of the tooth.
It's basically camouflage.
It is entirely camouflage, and for mild cases, this might literally be all the patient needs. It's safe, it's non-invasive, and it preserves the tooth structure entirely.
But what if that's not enough? Say the contrast is still just too high. What is step 2?
Step 2 is enamel microabrasion. This is where we get a little bit more active. We use a slurry containing 6.6% hydrochloric acid and silicon carbide grit. A very common product mentioned in the literature is opolyster.
And how does that slurry actually work?
It chemically and mechanically removes superficial stains in a very, very thin layer of enamel, usually no more than 100 microns. It also smooths the texture, which changes how light reflects off the tooth. A smoother surface reflects light much more uniformly, which helps mask that subsurface scatter we talked about earlier.
Now, I saw a specific note in the source material about burr selection here. This feels exactly like an exam trap.
Oh, it is a major safety check. When you are applying this slurry, you must use a specialized rubber cup in a gear reduction handpiece. You absolutely must run it at a low RPM.
Why is the speed so important?
Heat generation. If you spin a rubber cup too fast on a dry tooth, you generate friction heat incredibly quickly. In a young patient who has a large pulp chamber, you could easily cause pulpitis or even complete necrosis just by trying to fix a cosmetic issue. Examiners look very closely for safety. So low RPM, rubber cup, intermittent pressure.
Got it. Safety first, always. So, we've bleached, we've microabraded, but maybe the white spots are still there because the porosity is just too deep. This brings us to the relatively new kid on the block, resin infiltration.
Yes. This has been a total game changer in aesthetic dentistry. You might know it by the trade name Icon. It works on a completely different principle.
Well,
Instead of removing the defect, we are filling it.
you called this an optical trick earlier.
It is an optical trick. Remember, the white spot looks white because the subsurface pores are filled with air or water, and those refract light differently than healthy enamel. Air has a refractive index of roughly 1.0. Enamel is about 1.62. That difference is what causes the scattering of light.
So the light hits the air pocket and it just bounces back at you.
Exactly. Resin infiltration replaces that air with a low viscosity resin. And this resin has a refractive index that is almost identical to healthy enamel.
So when the light hits it, it doesn't scatter at all.
Correct. It passes right through. Visually, the white spot just completely disappears. It blends seamlessly into the surrounding tooth.
That is incredible. But here is where it gets really interesting for the people studying the current literature. There is a specific clinical pearl regarding the timing of this procedure for fluorosis, right?
Yes, and this is crucial for the exam. The standard instructions, which are often designed for post-orthodontic white spots, those might say to infiltrate for about 3 minutes. But the research on fluorosis specifically suggests that 3 minutes is nowhere near enough.
Because the fluorotic lesion is structurally different than an early decay lesion.
Yes, exactly. It often has a highly mineralized surface layer that is much harder to penetrate, and the lesion itself is usually deeper. The literature clearly indicates that extending the infiltration time to 15 or even 20 minutes yields significantly superior aesthetic results compared to the standard protocol.
15 to 20 minutes. That is a massive difference in chair time.
It is. And mentioning that level of detail, knowing that fluorosis requires a modified protocol, that is exactly the kind of thing that pushes a candidate from just competent to highly proficient in the examiner's eyes. If you just follow the box instructions for fluorosis, you will likely get a suboptimal result.
That is a golden nugget right there for the OSCEs. Okay, so that is the conservative ladder. But what if we are dealing with a TF score of 5 or higher? We have pitting. We have actual loss of enamel structure. The optical trick won't fix a physical hole in the tooth.
No, it certainly won't. When conservative measures fail or when the anatomy is already lost, we have to look at restorative options. This usually means either composite bonding or ceramic veneers.
And how do you justify choosing between them in an exam scenario?
Well, composite is additive and it's conservative. You can fix the pitting without taking away any more tooth structure. However, the downside is it stains and it wears down over time. Ceramic veneers, on the other hand, offer the absolute best aesthetics and longevity. But, and this is a huge but, they usually require the irreversible removal of tooth structure.
And we are very often talking about teenagers or young adults here.
Exactly. Putting a porcelain veneer on a 14-year-old is a major ethical decision. You are committing that tooth to a cycle of restoration for the next 60 or 70 years. The pulp is large, the gingival margin hasn't even stabilized yet. So while veneers are technically an option, an expert examiner will want to hear you hesitate. They want to hear you justify why you can't use a less invasive option first.
That actually segues perfectly into the next section. Communication and ethics. The ADC exams have specific communication stations where you have to talk to an actor playing a patient or maybe a parent. What are the big traps here?
The biggest trap by far is jargon. You absolutely cannot sit there and tell a worried mother that her child has myeloblastic disruption due to excessive fluoride ingestion during the secretory phase.
Yeah, I could see the actor's eyes glazing over already, or worse, than getting angry because they just don't understand what you're saying.
Precisely. You have to translate it. You say something like, the cells that build the teeth were a bit disturbed while the tooth was growing under the gum.
The tooth-building cells. I really like that. It's simple, but it's completely accurate.
Another crucial communication point is managing expectations. This is all about informed consent, especially if there is severe brown staining. Treatment often isn't just a quick fix. You need to explain clearly that it might take multiple stages. So whitening to lift the value, then the microabrasion to smooth the surface, and then finally the resin to fill the pores. You cannot promise a perfect Hollywood smile in one short appointment.
Right. Manage the expectations early. And what about the public health question? Because I could easily imagine the scenario where a parent asks, is the water safe? Did the tap water do this to my kid? Should I stop giving my other kids tap water?
That is a very high probability question for these exams. You must navigate this extremely carefully. You acknowledge that yes, the fluorosis is likely linked to fluoride intake during those critical early years. However, you must immediately pivot to the public health perspective.
Which is what exactly in the Australian context?
That in Australia, community water fluoridation, which is typically kept between 0.6 and 1.1 milligrams per liter, is considered the most effective and equitable measure for preventing tooth decay across the population. The view is essentially that we can manage the aesthetics of mild fluorosis, which doesn't actually damage the tooth's health. But tooth decay is an active disease that causes pain, infection, and tooth loss.
So we treat the aesthetics, but we don't throw the baby out with the bathwater. We still heavily value the protective benefits of community fluoride.
Correct, it is a balance. And demonstrating that you truly understand that balance shows the examiner that you understand the Australian healthcare landscape as a whole.
Speaking of that landscape, let's zoom out for just a second. What are the broader implications of this shift toward these highly conservative treatments we've been discussing?
It represents a massive shift toward preventative aesthetics. By managing fluorosis early and conservatively, using things like resin infiltration instead of drilling for veneers, we are actively preventing the cycle of dentistry.
The cycle where a small filling becomes a bigger filling, then it becomes a crown, then a root canal, then an extraction.
Exactly. If we can treat a 15-year-old with resin infiltration, that tooth remains essentially intact structurally. If we cut it for a veneer, we have compromised it for life. Reducing the need for complex restorative work in young people drastically reduces the long-term financial and biological burden on the healthcare system as that population ages.
It's really about playing the long game.
It is, and as healthcare providers, that is our primary responsibility.
Okay, so to recap our journey for you all today, we define fluorosis as a subsurface porosity caused by protein retention during tooth formation. We learned that the TF index is our absolute best friend in the clinic because it accounts for that biology and clearly differentiates between intact and pitted enamel.
We differentiated it from MIH by looking for symmetry. Remember, fluorosis loves symmetry.
And we climbed the ladder of intervention, bleach it, microabrade it very carefully with that low RPM rubber cup, and then infiltrate it. And do not forget that 15 to 20-minute rule for the resin.
And finally, communicate clearly in the OSCE. Use tooth-building cells, not ameloblasts. Be the translator for your patient.
Before we sign off today, is there one final thought you want to leave our listeners with as they prep?
I think the most provocative thing to consider right now is the rapid evolution of our materials. We are seeing resin infiltration become so incredibly effective for these defects. It really makes you wonder, as these materials continue to improve, will the concept of drilling a tooth for purely aesthetic fluorosis management eventually become completely obsolete? Are we looking at a future where the burr is only ever used for decay and never for discoloration?
Wow. That is a fascinating thought, a totally drill-free future for aesthetics. I think we would all happily sign up for that.
Absolutely, we would.
Well, that brings us to the end of this deep dive. For more ADC prep tips and clinical deep dives, please subscribe and share this episode.